Dr. Derek Lee. It's my pleasure to welcome Dr. Megan Johnson. Dr. Johnson is Associate Professor of Orthopedics at the University of Texas Southwestern Medical Center and is also the Medical Director of Ambulatory Care at Scottish Rite for Children in Dallas, Texas. Now, today, I really want to pick your brain a little bit on scoliosis bracing. It seems to be, a little bit of misinformation with respect to the proper parameters for bracing, when to brace, when to stop bracing. It's a huge spectrum in terms of information to cover. And so I hope we can kind of focus on that a little bit.
Sure, happy to talk about it.
All right. Now, it seems that scoliosis bracing is in a bit of a transition period right now, which I find really interesting. I remember when I talked to Dr. Stuart Weinstein about 2 years ago, we talked about his Iowa study in terms of the natural history of scoliosis if you didn't have surgery. But we also touched on his brace study, which in 2013 was pretty well just a randomized controlled trial looking at bracing and whether it was effective or not. And Dr. Weinstein did mention that he was pretty pessimistic in terms of if bracing really worked or not. He didn't think it did. And when he ran the study, of course, it proved to be at least about 70% effective in terms of stopping curve progression. And that was from curves from about 20 to 40 degrees. Over time, that seems to have played out, but there seems to be a bit of a shift in terms of bracing, not just stopping curves, but starting to think about reducing curves. And I was wondering if you can talk about a little bit about that.
Yeah, I think it's an interesting question. I think that study that you mentioned kind of opened people's eyes to the possibility of bracing being an effective treatment. And I think now that people have kind of accepted that, we are, I think, as a group looking towards how can we help those kids who maybe aren't great brace wearers? How can we, make bracing available to everybody? And, are there cases where braces are actually not just stopping the curve from getting worse, but is it actually possible that we can make some of these curves better? So, one of my colleagues who is actually a physical therapist but has a PhD is really interested in this topic, and I will give credit to her for being kind of the driving force on a study that we did looking at that question. And so she wanted to look at whether or not bracing curves under 25 degrees, which is what the SRS currently recommends, starting a brace at, could be effective. And she looked at, I think it was about 200 or so patients. And what she found was that kids who we actually saw some improvement in their curves tended to be younger, and they had smaller curves to start with. So, her kind of conclusion from this study and what we've kind of found is that if you do start a curve early, and if maybe your definition of early is a smaller curve size, or early could be a younger age than typical, that those kids actually maybe see some actual benefit in their Cobb angle instead of just stopping it from progressing. They're actually getting some improvement.
Yeah, it's kind of interesting because there seems to be more and more research indicating that seems to be a little bit more of a possibility.
Yeah.
Right.
And, I don't know that we totally understand why that happens. I wonder if there's some amount of growth modulation that perhaps we're actually getting with the brace. I think that's an area of research that kind of remains to be done, and something I'm interested in looking at in the future. But, kind of in the same way that people are looking at, vertebral body tethering, for example, like, are we affecting somehow the growth of the vertebral bodies in these kids who we see some good improvement in their curves? Or is it just that they're younger, their vertebral bodies are more plastic and moldable, and we're able to see some actual changes, like we do in other areas of pediatric orthopedics with bracing and casting? So I think it's a really interesting topic, and something we hope to research more.
Just to go on a little tangent, since you brought up VBT,
Yeah.
it's from the research I've read, it seems that a lot of the changes, especially with during the growth spurt, to the vertebra and disc complex. Most of it, of course, during their adolescent growth spurt, seems to be changes in a disc primarily, right? And when they hit more skeletal maturity over time, then it's more changes to the vertebra, right? Do you find that because it's more of a soft tissue modulation with the discs, that the bracing is having more of an impact on that initially, or it's just difficult to say?
Don't know. I think it's something interesting to look at for sure, because I do wonder, some of these braces that we use, really, you get some really nice curve correction, especially like the nighttime braces, for example. And I wonder what's really happening. Is it at the disc level, soft tissue? Are you getting some, vertebral body wedging changes because you're changing the stress relationship on different sides of the curve? So I don't know, but I think it's an interesting idea to look at.
Okay. Now, with the study you mentioned before, you looked at nighttime bracing versus full-time bracing.
Mhm.
Were there standard braces for both? So, for instance, was the nighttime bracing the Providence nighttime brace, or
Yeah, we at our institution, that's what we use is the Providence brace for nighttime bracing.
okay?
Yeah.
And with the lower, sub 25-degree curves, do you pretty much will start them off with a nighttime brace, and then when do you move them to a full-time brace?
Yeah, good question. I think there's not a standard. So there's 7 of us who kind of primarily are treating spine deformity, and then we have some advanced practice practitioners who do it with us too. I would say everybody's a little bit different. I would say as more and more evidence is coming out about the efficacy of Providence nighttime bracing and the increased tolerance and probably increased adherence to, the brace prescription, that a lot of us are more willing to try to start a Providence brace initially and to try to use it for curves that aren't just thoracolumbar or lumbar curves, because it's easier to wear. I think if you're gonna start committing a kid to a brace early on because you see that maybe there's a potential benefit to that, it's more palatable, probably for both me, the treating provider, and the patient's family to try to do it at nighttime first. And so I would say there's definitely been a shift, an increasing shift towards using that in the smaller, younger patients. And you also get, great correction in the Providence brace. So there's probably something to the fact that you're getting nearly 100% curve correction in that brace, and they're, wearing it for a good chunk of the day. But I do think we'll start to see more of a shift towards that direction as more data becomes available.
Uh, I know that some centers will do double bracing if you ever have to go to full time. So they'll do a similar Providence style of nighttime bracing with a Boston or Rigo Chanel style brace for the day.
Yeah.
What are your thoughts on that?
Yeah, it's not something I've commonly done. Maybe every once in a while, if there's a family who wants to be maybe super aggressive about bracing. Um, I don't know that there's a ton of information out there, evidence
Hmm,
support for that. I think conceptually it probably makes some sense. You're getting kind of massive correction at nighttime and then maybe less correction during the day, but still having that during the day. So I don't know. It's a good question. Not something I routinely do. You did ask earlier when to transition to a full-time brace. For me, it's if I start to see curve progression, despite wearing the nighttime brace well. Or I think there's some curves that are harder to control with the nighttime brace. So, some curves start out as maybe they look like they're going to be a primary thoracolumbar or lumbar curve. And then over time, maybe the morphology changes and the thoracic curve becomes more of a component. And then you feel like maybe you're not getting as much control out of the Providence brace of that. Or I think there's some kids who have this kind of massive like trunk shift associated with their
mhm,
scoliosis deformity. And in talking to the orthotists about their opinions, they find that to be, harder to kind of control with the Providence than a TLSO, because obviously you're wearing that more full time and you can
sure.
shift the body over more. But Yeah, the double bracing, I think, is an interesting concept and probably deserves some more study.
Sure. Okay. Yes, I just bring that up because in Canada, especially in Montreal, they do quite a bit of that, and the results
Yeah.
have been pretty interesting. Uh, with respect to bracing parameters, it seems, 20, 25, 40 degrees. Um, with research like yours, do you anticipate that they might start bracing even, 20 degrees sub 20, or does it depend on if there's a family history of scoliosis and, higher probability?
Yeah, I would say in my own personal practice, and I would say a lot of my partners, like, we will certainly be more aggressive about bracing smaller curves, so around 20 degrees, give or take. I do think that, family history for me plays a little bit into that, and I think partly it's also a little bit because the family's more keyed into it, or they have more of an awareness of it, and they want to be more aggressive, and so I'm okay with that. And again, I think because we've seen some, benefit and improvement in curves that are smaller in younger patients, it even makes me want to do that even more, because I think that's a great outcome. If you wear
Mhm.
a brace and you can get some improvement in your curve, that's wonderful. Um, and so, yeah, I think when I start to see these curves that are 20 degrees, especially in a younger patient, open triradiate cartilage, family history, I'm pretty aggressive about starting braces in those kids. I think for me, less than 20 degrees, I kind of let the families drive that a little bit. If they like really are anxious and want to do it, like, I'm fine to kind of start a Providence brace for that, a nighttime brace. But yeah, I would say for me 20 degrees, and I think that we will maybe start to see a shift,
Mhm.
hopefully down in that lower curve parameter, and maybe a change in the guideline at some point in the future.
So if you start off with Providence and it might show that the Providence is kind of failing because it's not holding the curve, and you have to go to full time. Um, how do you brace full time, or what kind of bracing do you usually initiate?
So at our institution, we we're using a generic, well, it's called a TLSO.
Mhm.
It's custom made in our in-house in our institution, so it's not sent out. And I, in particular, have an interest in the kind of Chanel style brace,
Mhm.
where anterior opening brace. And I'm hesitant to say Rigo Chanel brace, because we probably aren't really doing a strict Rigo Chanel brace. Here, orthotists have kind of customized it a little bit and made it their own kind of thing, though they are
Mhm.
kind of in that Rigo style. So I'll call it a Rigo style brace. But my kind of go-to is that anterior opening Rigo style brace. I'm kind of working on maybe proving this with our patient population, but anecdotally, I think that at least the patients I have in my practice seem to like the anterior opening better. I think it gives them a little bit of independence in terms of taking it on and off by themselves. And it seems that I think that the brace itself is more tolerable and maybe a little bit more comfortable. Just I think it tends to be a little thinner and lighter weight. And then, I would say a lot of families are interested in kind of combining bracing with Schroth therapy, for example, or some sort of like positional correctional therapy for their scoliosis. And that brace kind of lends itself, to doing that. And so that's kind of been my go-to when I, go to full-time bracing. And, a lot of my partners are still kind of using a posterior traditional
Mhm.
custom TLSO style brace, and works great, also. And so, in terms of prescription for me, I'm generally saying 18, to 20 hours a day.
Mhm.
And, we're using brace monitors and things like that to capture how much the patient's actually wearing the brace. But yeah, when I say full time, that's kind of, my go-to amount of time.
Right. Um, at what point do you well, let's start off with saying that, it's roughly about 70% success rate with bracing in terms of not progressing to surgery.
Yep.
But for those that do, what are your parameters for indicating that there is actually a brace failure and that you need to consider surgery at that point?
Yeah. I would say once the curve for me kind of reaches surgical magnitude, which would be, 50 degrees or
Mhm.
more, I'm kind of happy to keep bracing in the upper, mid to upper 40s if the family kind of buys in. If the kid is, super skeletally immature and their curve starts to get 45 or so, then I kind of talk to them like, hey, we are probably on the road to a surgical solution for this. I think if you guys are happy to wear the brace and it's working well, like we can keep that going as long as you all want. If it's something that's causing a lot of strife or we're struggling to wear it, then I, think it's okay to stop it because I think that the train is kind of going in a different direction for your child. But yeah, I'm happy to kind of take the family's lead as to what they want to do when those curves start to approach that 50-degree mark.
Sometimes I get the question in terms of, well, when is the best time to have surgery? Uh, it I know surgeons like to wait as long as possible in terms of maturity, skeletal maturity, because there can be complications if you perhaps fuse too early, that type of thing, right? Yeah. Can you talk about that?
Yeah, I mean, I think it's a little bit of a hard question to answer because there's a lot of different variables, curve
Sure.
size, morphology of the curve, if it's thoracic, lumbar, that kind of thing. But generally I think once they kind of get over 9 approaching 10, I think you're okay to proceed. I think a lot of families have it in their minds, yet the kids have to be done growing. Which in my mind is not necessarily true. I think once you've gotten to a certain amount of maturity, like the risks that come with posterior spinal fusion get lower and lower and lower. So, I'm kind of happy once they hit that, kind of close to 10 or approaching 10 threshold. It's nice for me. I would love their triradiate cartilage to be closed. I think that kind of lessens the risk of like adding on and things like that. Sometimes it's maybe not possible because of the magnitude of the curve, and you're maybe worried about it getting so big. But yeah, generally, I think once you kind of get to that point, it's fair game if the families are on board with it.
Can you put that in terms of skeletal maturity in a Sanders or Risser? What would you say it's in terms as
Yeah.
opposed to 9 or 10?
So I would say, Sanders kind of 3 is a nice
Okay.
spot to hit if you can. Um, Risser, I think, is a little bit more maybe problematic because it's a little bit more variable in terms of like patient's Risser status and where they are with maturity. But I actually do think the triradiate cartilage status is actually a helpful kind of parameter to go by.
Okay. Now, since we talked a little bit about the lower end of bracing 2025, there's a little bit of research coming out now about uh, at the higher range, 50 degrees in terms of some centers seeing, yes, stopping. I know there are other parameters in terms of skeletal maturity levels, et cetera. But have you noticed any in your practice any kind of signs of curve reduction at those levels, depending on spine flexibility, or has it played out that that bracing doesn't seem to do too much over 40 degrees?
It's a good question. I don't know if I have enough data to tell you with
Sure.
certainty. I do know that there are some studies coming out about those curves, and I think I can't say that I'm up on those specific studies
Okay.
yet, but I don't know that I've noticed necessarily a reduction in the curve when they get to that magnitude. But I mean, I've seen some kids kind of stay in that area, in
Mhm.
that range for a while and not necessarily progress. Is that um race related? Is it where they are in their skeletal maturity? It's hard to know. and it probably does depend on where the curve is, in their body, thoracic or lumbar, or
Mhm.
thoracolumbar. But I think the concept's super interesting, and, I'm happy again, like, kinda like I said earlier, I'm happy to continue bracing those kids if the family's on board. It certainly can't hurt,
Mhm.
and as long as it's not causing, psychological distress or family strife, I think it's okay.
Yes, yeah. I remember when my son was bracing, it was horrible.
Yep.
You just look at your son and you go, ah, I wish I could trade,
I know.
positions because, but you have to do, we have to do if you can do it right.
Yeah.
Now, I also want to touch on other bracing styles, perhaps. About the whisper brace a
Mhm.
little bit, right? In terms of, you have any thoughts on? I guess the compliance would be much better with that because it seems to, you move more. Have you touched on that at all with any of your patients?
So, I have probably 4 or 5 kids in a whisper brace currently. Um, and so I don't have a ton of experience. They've maybe the longest patient who's been in one is approaching a year. So I don't have a complete data set. And the kids that I have in a whisper brace, it hasn't been their primary, like, bracing, their primary, like, their first index brace. It's been kids who have had a really hard time with the brace that they were initially prescribed, and they've sought this other type of brace out because they've heard about flexibility and things like that. So I don't none of this is, take this all with a grain of salt. This is my handful anecdotal experience. Um, I think 3 out of the 4 kids who were struggling with their brace that they started with and then transitioned to a whisper brace have continued to struggle wearing the whisper brace. And so I'm not sure it's necessarily a reflection of the brace, but just they're not going to wear a brace. They're going to struggle with that. I do have one kid that my nurse practitioner has been treating, and she actually has done better in the whisper brace than she did in the other brace. So I think the whisper brace is a super interesting concept, definitely more mobile. Um, and I think that's certainly appealing. I would love to continue to see data come out about its efficacy, and I think it certainly could be a great tool for us and could be something that helps kids who can't wear a brace otherwise. I think we don't know yet. It's a little
Sure,
green.
absolutely.
Interesting concept for sure.
Yeah, it's easier to, it's it's interesting to talk to other practitioners
Yeah,
who are trying it because it is a little bit of it's an interesting concept, and parents, of course, are going,
of
well,
course.
especially if you had your first index brace and it's you're looking for
Yeah.
anything that's going to give you movement. Uh,
Yeah. So I'm happy to have a conversation with families, and I
mm,
try to be honest and tell them I don't have a ton of experience. This is a new tool in our tool kit. We don't really know
mm,
exactly how it's going to play out in the long term, but if you're struggling with one brace and you want to try this, I'm happy to
mm,
help facilitate that. I just don't know.
sure. And at least it gives you more options as well. You can start
Totally.
with the Providence, you can move to Rio type, and so at least bracing has a little bit of a spectrum on it as well.
Yeah, some options, which I think is helpful.
Okay. Now you've recently started a Brace Registry.
Mhm.
Can you talk a little bit more about that?
Yeah, we for a long time, I think have had an interest in bracing, and we have a really tremendous orthotics department here. Again, they make the braces in house. We work really closely with them, and it's an interest of mine. I think it's a really powerful and useful tool, and I think it deserves more attention. And
Agreed.
I'm a surgeon. I love to operate, of course, but these are big operations, and you know being able to avoid that for kids is obviously what we'd like to do. But so I think we have a large number of kids that we brace every year, and so I just felt like this was an area that was ripe for collecting data, prospectively, and trying to get patient reported outcome data and things like that, which I think will help us make bracing better for kids. And
Excellent. I think. The more research, the better.
Yeah, agreed.
Absolutely. I'd love to ask you a little bit more about the research paper.
Sure.
And it it kind of mentioned that for um, with, with the curves in this, well, with the patients in this study, when you compared Skeltie immature versus Skeltie mature, and it's, let me just read it because this will be easier if I do it.
Yeah, please.
Patients who were not Skeltie mature in brace discontinuation at brace continuation had lower Cobb angles as opposed to those who were skeletally mature, if I can say this properly, um, which I found kind of interesting because they always want the child to be skeletally mature before they discontinue the brace,
Mm-hmm.
as opposed to discontinuing when they're still growing. I'm
Yeah.
confused. Can you clear that up for me?
Yeah. So my best guess as to that is that I think some people, when they're treating the curves, like maybe they were small to begin with and they're treating them and they get better and they're kind of stable over time, like they will discontinue the brace because they, were kind of thinking like, well, if this patient walked into my office with this curve at this time point fresh, like I wouldn't have started a brace. And so they've achieved that and it's been stable over
Mhm.
6 months, a year. So like maybe it's appropriate to stop bracing even though they haven't reached maturity. You got a young kid and their curve got better, like I think it's to try to get them out of the brace.
Okay, that makes sense because I'm going,
Yeah, does that make
what's
sense?
going
I think it's just a reflection of the fact that the curves were small and, may or may not need bracing at that point.
on? Okay, and I just want to throw in that only 7% of patients in nighttime bracing and 8% in full-time bracing with open, cartilage, radiated cartilage, had to progress to surgery. So that's pretty amazing, actually.
Yeah, I mean, I think that's, hard to know. Is that a reflection of the fact that the curves were smaller to
Yeah.
begin with, and maybe they would never have gotten there, the natural history wise, maybe they would have never have gotten there to begin with, or is it
Mhm.
a reflection of the fact that maybe early bracing is a thing? I think
Mhm.
this is one piece of the puzzle, and we probably need bigger numbers and more evidence to really say that for sure. But yeah, I agree with you. I think typically you think of kids who are super young, open triradiates, fairly sizable curves, like, oof, this one is probably going to go on and progress. But
Mhm.
there's something to this.
For sure. We always have to look at the other variables involved,
Mhm.
specifically growth potential, right?
Yeah,
Um,
and I do think I think all of this bracing stuff at the end of the day, there is probably, I would say in the future, like future targets, there's probably some role for like AI and big data to like look at a patient and then be very prescriptive about their brace, like what kind of brace, how much they need to wear it based on, data. We're
mhm.
not there yet, but I think, maybe one day in the future, instead of just saying you're getting a full-time brace, it's 18 to 20 hours, we really can be very specific about what each patient's individual need is going to be. That would be cool.
That would be actually the best, just
Yeah.
because you can tell a patient, well, yeah, you'll wear it for 16 months,
Yep.
12 hours a day,
Yeah.
and that's what it's going to be, right? That would be
That's
amazing, eh?
the holy grail of all of this, I think. But because I think that's a super common question. How long is my kid going to have to wear this brace? How long am I going to have to wear this brace? And we can never really say that specifically. So, that the amount of time somebody needs to be in the brace, clearly not everybody needs the brace for 18 to 20 hours. Like, that
Sure.
just is probably not a one size fits all situation. So that would be something pretty amazing in the future if we could really get this down to a science.
Well, with your work, Brace Registry, and all
Yeah.
the all the science that's going on, it's great. It's
Yeah, and I
and with
think centers can combine efforts so you
Mhm.
get an even larger, number of patients. And then I think we'll probably get there at some point. When that is, I don't know. But I think there's a lot of room for improvement.
Okay, excellent. Okay, Dr. Johnson, thanks so much for your time. Thanks
Sure.
for educating me more on bracing, and I really appreciate it.
Yeah, happy to talk to you. Thank you for taking time to do the interview with me.